Dear colleagues, I've been asked by the editors to summarize in a video how to assess a patient with tremor. Franziska Hopfner has helped me with preparing this video that you will see now.
We've asked one patient to serve as our main partner for this video, but have also included some patients with specific findings which we will demonstrate at the end of this video.
Our patient is a 79-year-old businessman who has been running his own construction company until recently. He has by chance spent a few days here at the department because of carotid surgery, which became necessary after a transitory attack. I just mention this because you will see his wound dressing in some of the video clips, and this has nothing to do with his tremor. He experienced first symptoms of the disease as a teenager. In these days, he sometimes had problems during mental stress. Later, at the age of 40, he experienced the first problems with skilled motor tasks like grasping a glass. When he turned 60, we met for the first time, and since then I have followed him. We have tried all recommended medications, but nothing worked really successfully. He is handicapped, as can be seen in the following video, but he can cope with most of the problems. We have talked about deep brain stimulation, but finally we decided not to do this. Nobody in his large family has tremor. He knows about the effect of alcohol on his tremor and has taken advantage of this infrequently in the past when he had a difficult business meeting. The diagnosis of this gentleman is therefore early onset sporadic essential tremor, which is alcohol sensitive. What are the aims of clinical tremor assessment? We need a detailed description of the tremor according to a few criteria. The severity of the tremor can be nicely quantified with performance tests, and finally we have to carefully search for other symptoms than tremor. The tremor phenomenology is separated following different criteria. A very important one is the activation condition. Rest tremor is separated from action tremor. The action tremors are separated into postural tremor and kinetic tremor. Tremor when keeping an extremity constantly activated is typically tested with hands outstretched. Kinetic tremor may occur during non-goal-directed movements or specifically during goal-directed movements, which is then called intention tremor. Position and task-specific tremor is a rare variant of a kinetic tremor. This is the classical maneuver to assess postural tremor. Our patient is now performing slow alternating movements. The addition of a tremor on top of the voluntary movement can clearly be seen. Next is testing for goal-directed or intention tremor. This can be done during the finger-to-finger test or during the finger-to-nose test. Very often, intention tremor is not really regular, but comes with myoclonus-like jerks. This is how I assess force tremor, as proprioception is much more sensitive than vision, and I can easily feel the regularity of tremor. In contrast, this is a lady with a myoclonic tremor due to lithium intoxication, where I can feel the myoclonic jerks much better than I can see them. Typically, the patient is assessed in a sitting position with his hands resting on his lap and being distracted from observation of tremor, for example, by counting backwards in steps of 3. It is even better to assess the patient lying completely relaxed on a couch. While our patient has no resting tremor, this patient suffers from resting tremor as part of a very severe essential tremor. One of the challenging questions is to separate rest tremor in ET and Parkinson's disease. This can be done with the test for tremor suppression during movement onset. This is a video from a reviewer-blinded study. When the arm moves from rest to posture, the tremor is ongoing and can be seen during the lifting movement and posture. In Parkinson's disease, the tremor is suppressed during movement onset and may or may not return during posture. This is now another example of the persistence of the tremor during movement onset in ET. The suppression of Parkinsonian tremor can also be seen in daily activities like grasping. The tremor disappears during movement onset, and a higher frequency postural tremor occurs while the patient grasps the glass. When the arm is back on the armrest, the tremor reoccurs, but the important feature is the suppression and not the fact that it may reoccur during posture. Tremor frequency is separated into high, medium, and low frequency tremor. The first patient has a high-frequency co-contraction tremor due to psychogenic tremor. The essential tremor of our patient has a frequency of 5.5 Hz, and the last patient has a 3 Hz Holmes tremor due to a thalamic lesion. The topographic distribution of tremor is an important help to make the diagnosis. Head tremor is seen in our patient, but he does not have tongue tremor. As an example of a typical essential head and voice tremor, we show here the more severely affected lady with essential tremor. Leg tremor is a relatively infrequent manifestation of essential tremor. Our patient does not have it. In contrast, the more affected lady has leg tremor, which can be easily demonstrated. The severity of tremor can be quantified with performance tests. The ability to pour water from one glass into the other is used as a simple test while spilling is graded. Our patient would score 4 on a 5-point scale. Spiral drawing is another well-established measure of tremor severity and can be graded either on a 5-point or a 10-point scale. He would score grade 8 on the 10-point scale. The test is usually done with both hands. Just to illustrate the power of this test, we show here the myoclonic jerks produced by the lithium-induced tremor in the lady with myoclonic tremor. Two non-tremor neurological findings are frequently seen in essential tremor. The first is a slight ataxia of the hands, which is not seen in our patient. However, the patient with more severe tremor does have a dysterodochokinesis. This is sometimes difficult to separate from the action tremor. The other is a slight gait disturbance. Normal gait is usually unaffected and the patients do not complain. However, tandem gait is somewhat abnormal. The number of missteps is much higher in ET than normally, which can be seen clinically. The appropriate test is the tandem gait for at least 10 meters. However, the spectrum is large, as can be seen in the patient with severe essential tremor. She is almost unable to walk unassisted and needs help. This is a rare finding, but the diagnosis is established according to history and the long-term course. Other diagnoses are excluded with numerous laboratory and imaging tests. Eye movements are usually normal. This is true for both slow eye movements and saccades. Very subtle abnormalities can only be found with special equipment. They are not clinically relevant. Several conditions have to be excluded for every patient. The first is a neuropathy, because neuropathic tremor is a condition which is separated from essential tremor and may even need a different therapeutic approach. This is done just with standard neurological assessment. Another standard part of the neurological assessment is testing for Parkinson's disease, bradykinesia of hand movements, of finger movements and leg movements is standard. Rigidity should be tested for all extremities, and also stance reflexes. All findings are normal in our patient. Signs and symptoms of dystonia need to be carefully excluded. Tremor in dystonia is very common, and the severity of dystonia can be mild while the tremor is already severe. There are other causes of tremor which show symptoms other than tremor during the neurological exam. Among those are the very rare tremors following brainstem lesions. Essential tremor is a pure clinical diagnosis, and we need further criteria to define it. 3 criteria are considered supportive for the diagnosis of essential tremor. Despite sensitivity and specificity of these criteria is not yet fully known, we need a common understanding how to define them. Age at onset is defined according to the patient's recollection. A family history is assumed if at least 2 further members of the family are affected. Optimally, there should be an objective documentation that they are or were affected. The diagnosis of alcohol sensitivity of the tremor is usually also based on the patient's recollection, but can be diagnosed with a simple and reliable home test. The patient is asked to drink a defined amount of alcohol and asked to draw several spirals with each hand before and 40 minutes after alcohol ingestion. We aim at an alcohol content of 0.5 per million, and the amount of alcohol which must be consumed can be calculated if the body weight is known according to the Widmark formula. The spiral scores are rated according to the 10-point scale of Bain and Findlay. Our patient participated some years ago in this home test, and you can see his spirals before alcohol ingestion on the left side and after alcohol on the right side. The upper row shows the result for the right hand and the lower row for the left hand. Thank you very much for your attention.